On behalf of the MBSC and Dr. Keith Coker and Medic, I'd like to welcome everybody to our joint session today. I got to tell you, we're really excited to be here together, and we're looking forward to discovering opportunities to improve patient care, especially where our collaboratives intersect. I want to welcome some of our partners and guests, specifically Blue Cross and Blue Shield, Michigan Value Collaborative, Marquee, and My Mind. And then we have 3 patient advisors that are here today, Rosemary and Don Griffins, as well as Mike Adams. Thank you for being here today and providing the patient perspective. A couple housekeeping items on your tables. It does tell you the Wi-Fi password. And please remember to wait for a mic before you ask your questions. This way everybody can hear it, and additionally, it can be then captured for our recording of this session. This is our disclosure slide. All right. I know Medic has done this before, but MBSC, we have not shared unblinded data. We're going to be doing that today. Just want to remind everybody that this is sensitive information. Please don't take any screenshots or share any of the confidential information that we discussed today outside of this meeting. You need to claim your CME within a week of this meeting, and either later today or tomorrow, you'll receive an email that has the information on how to claim your credits. All right, I'd like to welcome Dr. Keith Coker up to the podium.
Sorry. All right, great to see everybody here as well. Welcome you to the joint meeting. I'm going to work through a couple other items and then get into the agenda a bit. So as I was saying, I'm Keith Coker. I'm one of the emergency medicine doctors at University of Michigan and one of the medical directors of Medic, so the ED Quality Improvement Collaborative. One programming note here, we have a poster session for Medic folks from different sites. So you'll see some postings around the room. Please engage with them at the lunchtime hour. All right, so this will be the agenda. We're going to set up the morning here, and then Art and I are going to trade off just kind of providing an overview of our different collaboratives so you have some understanding of the work that we do. And then we'll have our expert outside speakers come to the podium. We'll introduce them at that time. And then we're going to break out into quality improvement activity. And we'll set that up at that point. We'll have lunch. And then we'll break out into our different collaboratives in the afternoon sessions. Okay, so why are we here together? Well, I think from my perspective, there's a lot of overlap in interdependence between the emergency department and surgical services and surgical care. Certainly speaking from the perspective of my vantage point in the emergency department, we truly rely on the capabilities and support from surgical services. We rely on the units and operating rooms for the patients that we serve in the emergency department setting. And I would imagine surgery services really rely on the diagnostic and treatment capabilities in emergency departments. We may not be perceived as the speediest of services, but we are the only location really where patients can access this kind of service universally in our healthcare system. And with respect to post-op care, complications from surgeries, we all have a shared interest in making sure there's standardization around those evaluations, that we have smooth care coordination and workflows across teams and units. So let's get a little bit more specific here and talk about, what's in scope for the meeting today. Certainly understand and acknowledge that the delivery of surgical care is really important. All of the techniques, the post-op, the follow-up, really important. But for the purpose of the meeting today, that's going to be out of scope. What is in scope is this overlap between those patients who are experiencing post-op problems as they intersect with the emergency department setting. And for those that are maybe not as familiar with how the care processes in the emergency department occur, let me just kind of walk through the schematic here. So there's generally going to be a triage process that occurs as you enter into the emergency department, and that rapidly transitions into an evaluation phase. And just sort of make sure that you understand, like, patients will come in with diagnoses. They come in with symptoms. And it's going to require some testing, some treatment, sorting through of a differential diagnosis to arrive at the diagnoses that may be under the symptoms that somebody is having. And that's going to take some time. And within that process, with respect to post-op problems and complications, usually we're going to have some interaction, some consultation with a surgical service. The timing of that's going to vary. And I think that's part of what we're going to be talking about today. And always in the back of the mind of, the emergency department setting, is our favorite phrase, which is disposition. At the end of the day, what is the next step in care here? And that's always in the background of our heads. Is this somebody that's going to require the hospital, an operating room? Is this somebody that gets discharged home? And what does that follow-up look like? So that's the scope that we're talking about. And so just kind of keep that in mind as we work through today and get into particularly that QI activity. So as I think about this overlap, this is really a whole workforce problem and challenge. I've listed out several of the critical actions as I think about them in the emergency department setting. As I mentioned, there is this evaluation and tailored testing phase, where you have some uncertainty at times about the diagnoses, and you're working through, what those could be. There are going to be some time-sensitive treatments, perhaps at play. If somebody is having sepsis, obviously there's going to be a lot of time-sensitive interventions that are required. There's going to be a need for clinical reevaluation and assessment, understanding, do we need escalations of support? And obviously, as I said before, really this kind of key component around disposition planning. And underpinning all that is going to be the need for care coordination across teams and units. So I think this is where the rubber hits the road, is these zones, what we're calling zones of vulnerability. And we've listed them out here in the schematic. These sort of points of conversation between teams and units. And they're going to be these structural and system kinds of barriers that interfere with some of the smoothness of those interactions. Surgical services have competing demands at any given moment. Responsiveness and access may vary. The ability for timeliness of follow-up cares, if somebody is discharged, what does that look like with any particular health system? And certainly from the ED perspective, we're always up against the problems of crowding and boarding, and the realities of shift change. So these are some of the structural challenges around creating smooth coordination. So as we move into the quality improvement side of things, particularly as we're setting up this activity, I think it's just really important that we keep in mind the right mindset here. You always want to approach these problems with curiosity, approach it with the principles of just culture. So we're not going to blame an individual. We're going to think about what is interfering with why that didn't work. What are the structural, again, and process barriers that are interfering with smooth care? And of course, all team members have expertise. I as a physician may have a particular perspective, but I really don't know how ED nursing care works, for example. And so all team members are going to have some input into how to do things better. And then, of course, solutions are always local. What works for one hospital, health system, emergency department may not work for another. So just some key things to keep in mind as we work through solutions. All right, so I'm going to switch over to the sort of next agenda here, which is to begin provide some overview of our respective projects. So I'm going to talk about MEDIC first, and then I'll hand things back to Art to talk about MBSC. So this will be kind of a high-level overview. You know, I think my vantage point in MEDIC is we're really, at the end of the day, a learning health system. We take evidence, knowledge that's in guidelines and recommendations in the medical literature, apply that knowledge to practice change within the emergency department setting, collect data along that way in the measurement and the reporting that we do. And we learn from that data collection, generate new knowledge, change practice again. So we're in these cycles of improvement. We're in close to 60 hospitals across the state. We represent almost half of all the emergency department visits that occur annually. We also have a robust portfolio within pediatric care, and so have all the major pediatric centers in our network as well. And so this is kind of the sweet spot of where we want to be, you know, where there's high quality evidence, gaps and opportunity, and at the end of the day, impact, where those circles overlap. And as I mentioned, so do this process of knowledge translation, oftentimes relying on things like choosing wisely to identify the quality measures and initiatives that we're involved with. And they largely fall into three different categories. We focus a lot on utilization of radiology imaging, particularly CT scans and X-rays in areas of care where we have good evidence to guide those decisions. We also focus on this hospitalization decision, which is really a key moment in anybody's patient's journey that has a lot of costs associated with this. So particularly around chest pain decision-making in adults and process measures for children with asthma, and then some population measures around harm reduction for opioid use disorder, for distributing naloxone and smoking cessation counseling. We provide, you know, as all CQIs do, a lot of implementation support around those quality initiatives. This is off our website, and a lot of our materials are housed there. We do something maybe a little bit different than some of the other CQIs in that we have a registry where we move a lot of the data electronically through data feeds from hospitals. And then we supplement that with abstraction and drive a lot of our quality reporting as a result of all that data collection, and have built out a Tableau-based reporting capability. So I'm going to zoom out a little bit just to get you some perspective on impact. This is zip code level patients that are cases like in our registry. You know, it's a density map here. You know, a lot of this has to do with where our hospitals are located across the state. And if you zoom out even further, we actually have patients that are in our registry from really across the United States. Another way to think about our impact and the sort of breadth of our work has to do with what kinds of clinicians and physicians are in our registry. We have about 1,200 emergency medicine docs. If you expand that to include other clinicians like APPs, residents, fellows, we're close to 4,000. And then if you even broaden that further with nurses, social workers, we're up to about 17,000 unique clinicians in our registry. And this is an overview of our impact across our initiatives. A lot of this is about avoiding low value care and estimates of some of the spending that we avoided as a result of the improvements that we have across our quality initiatives. And then finally, you know, we're really proud about the partnerships and collaborations that we've developed over the years. And certainly Really proud that we now have this relationship with MBSC as a partner as well. So I appreciate your attention for all that. I'm going to hand things back over to Art here to give an overview of Bariatric Surgery Collaborative. Thanks.
All right, thanks, Keith. So the Michigan Bariatric Surgery Collaborative mission statement includes an aim to innovate and improve the quality of bariatric surgery through the use of data, evaluation, analysis of clinical data, as well as really our collaboration in this collaborative. To be successful, it takes our entire membership in the MBSC, including everyone in the state. But I do want to highlight, we have an exceptional leadership team that are highly engaged and really dedicated to driving quality improvement. And I'm very fortunate to have them as part of our team. Since we started in 2006, we now include 95% of the bariatric surgeries performed in the state of Michigan. Includes 41 sites throughout the state, over 80 surgeons, and our nurse abstractors, over 60 of them. Our data registry includes over 140,000 patients, and our data elements are acquired by baseline questionnaires, 30-day chart abstraction, which includes the entire surgical episode of care, as well as patient-reported outcomes annually for up to 5 years. Arbormetrics supports our data registry and allows us to have, real-time on-demand reporting of, risk-adjusted outcomes. And that allows us to also compare it at the hospital level as well as the surgeon level. And we can even drill down on real patient-level details. I know this slide is busy, but we've been really busy since the inception of our collaborative. Our work has generated now about 150 peer-reviewed publications. And more importantly, we're highly regarded as really innovators and quality leaders in bariatric surgery. And we have not only national, but international influence. What I'd like to do is something a little bit different, but I'd like to give some examples of some of our initiatives that we've done and how that's impacted our outcomes. For surgeons, reducing complications is a top priority, and we've done a bit of work on this. Early on in our collaborative, there was a wide range of insertion of preoperative IVC filters to prevent pulmonary embolus. When we analyzed the data, what we found actually is that these IVC filters were actually causing harm to patients. And if you look at the blue bars, those are the IVC filter patients. Of the patients that died that had IVC filters, half of those were directly attributable to the IVC filter itself. So we implemented an initiative to really reduce these preoperative prophylactic IVC filters. And within 4 years, we were able to completely eliminate that practice. And we estimate that we saved about 4 deaths per year, but about 68 deaths over those 17 years, and reduced annual costs by about $5.5 million. This is one of our most impactful publications, looking at really a novel way to assess surgical skill and compare it to surgical outcomes. And so what we did is videos were blindly reviewed, videos of laparoscopic gastric bypass operations by surgeons in our state, and they were directed to assess the surgical skill with this structured assessment. And then the novel part really was taking that information and be able to leverage our registry to look at risk-adjusted outcomes and compare it to surgical skill based on the video assessments. And what we found is that high surgical skill was associated with lower rates of complications, as well as lower rates of ED visits, readmissions, and operations. The best part of this project really was the second phase, and that was, what do we do with this information? How can we use it to help rise the tide of surgical skill throughout the state? And we developed this surgical peer coaching project. In this initiative, brave surgeons would bring a video of one of their bariatric operations, and they'd be matched with another surgeon. They'd watch the video together and look for opportunities to optimize technical skill. Based on all this, we're able to reduce complications in our state by 38% and serious complications by nearly a third, by reducing mortality 60% over that period of time. Postoperative venous thromboembolism, that can be a devastating complication, and we have done a ton of work in this space. Most recently, we developed a venous thromboembolism risk calculator. And this app basically calculates specific individual risk for developing a VTE. And then it provides risk stratified treatment guidelines regarding the duration and the intensity of chemoprophylaxis, especially on discharge. With all of our work, we've had real great success over the past 7 or 8 years, reducing VTE rates by 75%. And currently, we have the lowest rate of postoperative VTEs we've ever had in the state of Michigan over the past 20 years. Less than 2 out of 1,000 patients. I think we're all pretty aware of the opioid issues that we have. And when we started looking at this and analyzing our data, we found a couple of things that were interesting. One is that higher rates of prescribing opioids on discharge were associated with higher rates of complications, higher rates of ED visits and readmissions. Additionally, there's something called new persistent opioid use. That's if a patient is not taking any opiates when they come in for surgery, and they're still taking opiates a year after surgery. So they start developing and they're still taking opiates that they got maybe on discharge prescribing. Our rate at that time was about 6.3%. Additionally, we identified we were prescribing a lot of opiates. You can see there we are giving about 170 morphine milligram equivalents on discharge to our patients. And so we embarked on this initiative to reduce our opioid prescribing using MOPN guidelines to help guide us. And we've reduced our MME prescribing by 76% over this 7-year period of time. Interesting, the orange line, we now have about a third of our patients go home without any opioid prescription at all. And they usually go home on post-op day 1 or 2, which is pretty impressive. New persistent opioid use, if we go down to our baseline, which is 6.3% before we started this initiative, we actually reduced new persistent opioid use at 1 year by 90%. And now less than 1% of our patients have this issue of taking opioids a year after surgery. All right, something relative to the MEDIC collaborative, I'm sure, ER visits. And we looked at this, and when we initially analyzed this, we were looking at process measures. So about a dozen or so process measures that are noted to have an impact on ED visits. And when we looked at all those things, like, in other words, calling your patient, 48 hours after discharge to see how they're doing. But when we evaluated this, we found that there was no association between adherence to these process measures and actual ED visits. And we did root cause analysis. We identified a couple opportunities. One was that patients weren't contacting their surgical teams before they showed up to the ED. So we weren't able to really help guide them on how to best, get the best site of care, maybe come to the office, maybe they don't even need to be seen. And so we developed this way to increase communication with our patients. We developed these wristbands and wallet cards, and most recently, these magnetic photo frames that have a 24-hour helpline for our patients that they have ready access to. They can contact their surgical team and get better guidance on how to approach their care. Additionally, we encourage our sites to develop some relationships with alternatives to the emergency department, things like urgent care centers, rapid infusion centers, because sometimes patients just need some fluids or a lower level of care. With this, we have been able to reduce our readmissions by 57% and our ED visits by 22%. And I would say that we still have some room to work that. And hopefully we'll have some ideas today. It's interesting to note, of the patients that do come back for an ED visit, 16% of people, 16% come back again for another ED visit within those 30 days. So maybe that's an opportunity we can look at today to improve maybe communication or follow-up to help us reduce that revisit to the ED. We have been very fortunate to have some meaningful collaborations with some of the other CQIs. And, hopefully this joint session is the impetus for another wonderful collaboration with MEDIC. All right.